Namaskar and good evening to all the viewers of this podcast. So today this is 338 Gyan Pravah series of podcast, which is the brainchild of our Fogsi President, Dr. Sunita Tandulwadkar, Madam. She needs no introduction. She is the head of the Department of IVF and Endoscopy Center, Ruby Hall Clinic, Pune, founder and medical director of Solo Clinic IVF, and she is presently president of Fogsi. She is President-elect Ishaq for 2024-2026, and she has served at various capacities, many platforms, and she has also received recently FRCOG Award and Rashtriya Gaurav Award, Punya Shloka Award, letter of appreciation from President India, and Madam also has received Sarvasri Award. So we all know she is very active and dynamic personality, and she has brought many projects like Sampurna, Dhoti Ke Jindagi Ke, Legal Project, and Know Your Number, by which we all are getting from all women of age group, adolescent to menopausal age group, our blood pressure, weight, height, and blood sugar. So all these things have been done, and this has been planned by Sunita Tandulwadkar Madam, and this podcast series is also being planned by her. And today is this 24th December is the last podcast for me. And I'm happy to introduce a giant personality in Fogsi. In fact, I think in global world, in obstetrics and gynecology group. So Dr. B.P. Pally sir. So sir, Dr. B.P. Pally sir, full name is, I think, Vakanal Pally sir. So it's great honor for me to introduce sir. Sir has completed MD MRCOG from Edinburgh FRG. Actually, reading his CV will take more than 1 hour. His CV is about 33 pages. But I am reading only important things. Sir has served as a teaching faculty in various hospitals of India, UK, Saudi Arabia. He is senior consultant, Gani Hospital now. Sir has published many articles in journals, books. His article, Hemocysis in Placenta Accreta Syndrome, by manual aortic compression, and by doing applying autoclamps, limited resources, has get much popularity. And this article has been published in American Journal of Obstetrics and Gynecology. Sir has served Fogsi as the national president and many more associations in various capacities. He has been invited as faculty in many national as well as international conferences like FIGO Regional Conference, Dubai, Brazil, Tokyo, British Congress of Obstetrics and Gynecology, London, all IOGA annual meetings. Sir has attended all IOGA meetings as a faculty, all FIGO annual World Congress like in South Africa, Toronto, Washington, DC. He has given many orations in all the national as well as international conferences. He has been also invited as faculty at WHO workshop on maternal death, London. And sir has designed many clamps. He was also guest speaker at FIGO and SAFO, SLCOG, FIGO Toronto, staging and management of the genital prolapse. And sir had designed so many clamps and forceps like aorta clamp, transvaginal uterine artery clamp, the T clamp, transabdominal T clamp, Peli obstetric forceps, both regular as well as mini, Peli reverse angle transvaginal oophorectomy clamp, and TOT. It is cheaper rate for stress urinary incontinence. Sir has received many awards. Just to name a few: Medal for Distinguished Services to Women's Health, awarded by Royal College of Obstetrics and Gynecology, UK, on 22nd September 2025, recently. Congratulations, sir. Best Doctor Award 2023 for meritorious and dedicated services to the humanity, instituted by Health and Family Welfare Department of Government of Kerala. Distinguished Service Award from IME Thrissur. Thecklin Parambil Award for Outstanding Old Students by Alumni Association of St. Joseph's High School. Dr. B.N. Purandare Award from Mumbai Afghani Society. Appreciation Award for Empowering Youth with Surgical Skills by North Zone Yuva Fogsi. For Division 2018 Appreciation Award in recognition of a lifetime dedicated to women's health. North Zone Yuva Fogsi Conference 2018 Appreciation Award for exemplary contribution in the field of obstetrics and gynecology. Fogsi V for Stree Superheroes Award presented to Yuva Fogsi South Zone. Visionary Award for Kafok for exceptional foresight and outstanding contribution to the cause of reducing maternal mortality rate in Kerala. Best Doctor Award from Rajagiri Hospital on Doctor's Day for selfless services, professional excellence, and sustained contribution in the field of obstetric gynecology. Dr. Raja Gopal Memorial Award for Thrisis Shrudaya Vedi for Best Doctor in 2019. I think Sir deserves many more awards, and I wish Sir should get President Award also. So, just Sir, you say a few words about you, and then how you did all these things. So just you say, and then we will start the podcast. So.
Thank you, Kavita. I hope I am audible and clear.
Yes, sir.
Yeah. Thank you for this honor. And of course, our President Fogsi deserves all the credit for arranging this series. Sunita had been doing wonderfully. Thank you, Sunita. And thank you for this opportunity. I could do many of these things only because of support from my colleagues in Kerala Federation of Obstetrics and Gynecology, and of course my family support. Thank you all for recognizing and then asking me to give this podcast. Thank you, Kavita.
Okay, sir. Thank you so much. So we all know pelvic organ prolapse is very common, especially in menopausal age group and in rural areas in our part. So, sir, what do you think? What is the best way to diagnose pelvic organ prolapse? So, the topic is management of prolapse, knowledge versus action. So, just I want to know what is the best way to diagnose this pelvic organ prolapse?
Actually, the good thing about prolapse is for the diagnosis, you need only clinical examination. You don't need sophisticated instruments, radiology, and other things. Even ultrasound. Rarely only you need these additional procedures, but clinical examination will help us to know and quantify the prolapse, the type and the quantification or the extent of the prolapse. One unfortunate thing is, even now, in our country especially, the recommendation by the IUGA and the International Continence Society to quantify prolapse, that is the POPQ, pelvic organ prolapse quantification, is not taken up widely. People say that it is too cumbersome, too difficult and all that. As far as I am concerned, ever since this was brought in 1997, we have been following it. And once you regularly follow it, it doesn't need any extra time, it doesn't need any extra equipment, but what you record as POPQ, the 9 points, will help us to, when we review the patient, whether she has progressed from the time we saw last, or whether it is reduced from the time we saw last, or our surgery once we have done in the follow-up, whether she is keeping up the good results. All these are possible if you follow the POPQ. And what I have done is, I don't know whether you can see it, develop a model like this. I think the image, yeah, okay. Develop. I don't know whether you can see it, you cannot see it. We have this model to teach our students where we can show the different degrees of prolapse coming out like that. And each level, we can then teach them how much is the anterior wall, how much is the posterior wall coming like that. So anyway, it is not very clear, but I hope we can make it out. So we can keep it at different levels and then teach our students. I think such a training will help our students also understand the various levels of prolapse at the different levels. I feel strongly that POPQ should be followed by everybody. And because people have been complaining that it is so cumbersome, IUGA itself has come out with a simplified version. For A anterior and B anterior, A posterior, B posterior, all these are taken away. Anterior, how much is coming down? Posterior, how much is coming down? Rather than dividing into point A and B. And that is a simplified version that is good enough. But some sort of quantification is important. One other thing that people usually miss out is not doing a rectal examination. Every patient with prolapse should have, in addition to what is recommended in the IUGA POPQ, we should always do a rectal examination to see if there is a rectocele. And similarly, we should always check whether there is a paravaginal defect. How deep is the lateral sulcus? These two have to be added to when we write the IUGA, the 3 by 3, that's the 9 points, description of the prolapse. That's my feeling.
Yeah.
Takeaway.
So I think you have explained everything, and the way you are teaching students with model, with POPQ classifications, I think this should be popularized among all the students in the colleges, so that they should learn, because POPQ is, I think, best way to classify prolapse. So the way you are teaching should be spread to, sir, all the students. We all should know this way, that what is the degree of prolapse and what is the descent, and POPQ, I think, best way to quantify. So thank you so much, sir. Sir, we all know there are so many risk factors for prolapse. So what do you think? Can we minimize, especially in our part?
I think, unfortunately, our Indians, we have a predilection to have prolapse more. Whether it is genetic, whether it is nutritional, racial, we cannot say, but we see massive degrees of prolapse in our country, much more than in some other parts of the world. I have been fortunate enough to work in different settings, the UK, in Saudi Arabia. There itself, we could see the locals, the Bedouin families, and also when we work in the UK, you can see a very assortment of people from different races. And one thing I have noticed is the black race as a whole has less of prolapse than we, the Asians, as well as the Caucasians. Unfortunately, in India, especially certain parts of India, the degree of prolapse is so high. But I feel that there may be many factors contributing to it. One of them may be genetic. The tissue fibrosis or suppleness is different. If you see in African women, the uterus itself is so rigid, it won't come down. The ligaments are so strong, and they have more of fibrous tissue because, as you probably know, they have more of fibroids. So
Yes,
there may be a genetic factor. The second thing is large number of childbirth, more chance of this one. There is no doubt that vaginal birth contributes to weakness of the pelvic supports. So more the number of deliveries, more likely. More close together deliveries, more likely. And those who have damaged pelvic floor due to childbirth injuries, especially if you happen to bring out a big baby with traumatic forceps delivery or venous delivery, stretching all the structures and not allowing enough time for that to recoup and regenerate will lead to more prolapse. Very close childbirths, before time for the tissues to recover, if you have another heavy uterus coming and bringing that supports weak, that will lead to prolapse. So all these various factors are there, but I have no doubt that there is a genetic element. There is contribution from childbirth. There is the occupation also contributing. This was revealed even centuries ago when in Manchester, they found that the young white women who were employed in the factories, cotton mills, were the ones suffering from young prolapse. And that is the origin of the Manchester surgery or Fothergill surgery. Now, my colleagues working in the Himalayan borders tell me that the Tibetan women who have to carry large loads, maybe firewood or other things, had the loads, and they have massive degrees of prolapse. So whoever is employed such a way that they have increase in the intra-abdominal pressure, and that too continuously, is likely to have more of prolapse. Only understandable. People say that prolapse is a price that we pay mainly for the upright posture that human beings have inherited. So because the gravity effect will be more in our upright posture. We don't see that much in the quadrupeds, you see. So all these are contributing, but what we can do in a way to limit is have enough time to recoup after childbirth, avoid traumatic deliveries whenever possible. We cannot say you don't have vaginal delivery. That's not the answer for that.
Yes, sir. Yes, sir. So I think you have explained everything. So the posture which we have, along with certain genetic predisposition, along with many deliveries, especially difficult vaginal deliveries. And along with the work occupation the women are doing, and certain medical factors also. So the woman if is having chronic constipation, which will
Very true. Very
which
true.
will
Very true.
make them to strain. So everything will predispose. If the woman is already predisposed, and these will add on, so they will have more chances of prolapse. Sir, this is about multiparous, but what are the incidents and risk factors about nulliparous prolapse? Because many men are nulliparous, but they are still having prolapse. So what do you think? What can be the cause in that case?
See, I think when we talk about nulliparous prolapse, we have to accept there are mainly two types of them. Whenever a cervix projects outside the vaginal introitus, we say it's prolapse. But that need not be due to weakness of the supports. It can be due to hypertrophic elongation of the cervix. That, etiology-wise and treatment-wise, is different from somebody else who has very weak supports at a young age. Let me just answer this call. I'm in meeting, please go on. Okay. So if it is weakness of the supports, then it is not elongation alone. There may be an element of elongation, but mainly the level 1 that we talk about, the vault, also will come down with it. They may have poor supports of the walls or the anterior and the posterior compartments, so they may have cystocele with it. They may have rectocele or enterocele with it. So that is the real weakness of the supports. The other one, they may have strong uterosacrals, but elongation of the cervix takes place because of hypertrophy. And what leads to that hypertrophic elongation? We are at a loss. We don't know why it happens in some women. But it is not at all an uncommon problem. And we have developed our own technique of tackling it. If there is time, we can discuss that.
Yes, sir. Right. So I think some women have tendency to develop, and it can occur in nulliparous women also. Sir, what do you think? Especially in our part, in Bihar, UP, Jharkhand, Odisha, where the women are so much literate. So do you think they have knowledge of what are the risk factors which are causing prolapse? What is the knowledge of women towards risk factors which are prolapse? Because I think they are not aware. So what do you think? Do they have knowledge?
Yeah, I'm sure that is a question of education of the girl child that is boiling down to it. Once they are educated, they may come to know better, they will be reasoning out better. And of course, it is not just one factor alone. An educated girl may not have that many 10 deliveries. They may restrict the family, they may be employed. So they are all going together, not one isolated factor. It's unfortunate that in many places, many communities, women do not get the respect as well as the treatment they deserve. That also contributes to it. Lack of awareness certainly is a factor, because it may be lack of the formal education, or it may be social and circumstantial. What society expects out of a woman. In some parts of the world, they are expected to bear any number of children without any interval between. So all these social factors contribute to it. The women's awareness of the reasons for prolapse, as such, how much of preventive steps she can take, other than, of course, preventing very close together childbearing, not taking enough rest postpartum, and all these things. Other than that, I don't think there is very little she can do to prevent it. What I mean is, people say that if you take pelvic floor exercise and all that, no, I don't think that is a major way of doing anything positive about preventing prolapse in those girls. What is required is good nutrition, good interval between childbirth, have safe delivery, and have safe and proper postpartum period. More important, if she is to go and carry bundles of firewood or big pots of water within 1 week of delivery, then she will surely have problems.
Yes, I think there is a lack of knowledge, and you are right that the girl should be educated about this during her school age group, so that she can take all the preventive aspects. She should know the risk factors of the prolapse. Especially in our part, we see many cases of prolapse. So I think, and even younger age group like 30, 32, they are 5th and 6th para, and they are coming with something. Today also I saw a woman just 30 years old, and many women are starting their family, and she is having 5 children, and she's having something coming down. So I think this education should be given to the girls, especially during adolescent age group, so that they can understand what are the risk factors and how to prevent. So especially family limitation and preventing difficult birth, preventing heavy loads. So these all should be combined. Sir, why there is significant gap between the women's knowledge of prolapse and actual adoption of preventive management practices. Many times, women are aware that, by carrying heavy loads, this took this. After birth, she couldn't take proper rest and she had to work and she developed. So, what there is a gap? What do you think? What can be the cause?
Sorry, it's not clear, Kavita. Can you repeat the question?
Sir, why there is significant gap between women's knowledge of prolapse and actual adoption of preventive or management practices?
Yeah. I think that the society has to, the community has to take the onus of that. Because considering the type of background that we mentioned about the background of the woman, if she is not able to make decisions on her own, if she is forced to do these things that we said are likely to lead to prolapse, she is helpless. So it is actually a change that can happen by overall, what we would say, respectful maternity care. We talk about respectful womanhood.
Yeah.
She has to be respected if she is a mother. She is doing the reproductive function to be considered as honor and a service to the society. We do the other way. We are expecting that it is her duty to do that. So the respect that girls and women enjoy in the society is the factor that we should talk about. And that is, once it is absent, of course, it can lead to more of these problems for the woman. That's how I would look at it.
I think, sir, government, society, family, everyone should support these things. And this should be propagated to the woman that she shouldn't work after birth. She should take proper rest, adequate nutrition. So I think this should be done by government as well as by the society members also. So it should be at the level of family, but should be supported by, I think, all. What do you say?
The point that you mentioned, especially about nutrition,
yes, sir,
is very important.
Yes,
many of them get to full-term anemic. Postpartum, yes, after the blood loss, they are still worse, and they continue to lose their body stores by breastfeeding.
Yes.
So perpetually she is led to a stage where she is weaker and weaker, and obviously supports also will get weaker. That is how we can easily identify it. In some parts of our country, especially in certain states, because I move around in different parts, there are some parts of our country where massive prolapses. I cannot imagine how they walk around with such degrees of prolapse. Yes, but sir, woman suffers in silence, suffering all these things. And once it is there, it is like the frog in the put the frog into a boiling water, they will jump out. But if slowly you heat the water, they will tolerate it and finally die in the water. Like that, our women, they are in that sort of a circumstances and they are suffering in silence and they tolerate it. Finally, they collapse. That is what is happening. This is a social factor rather than anything else.
Yes, sir. Yeah. So I think everybody should join. Families, society, and government. They should support the women that you have to take rest, you have to take everything, proper nutrition, and avoid multiple births. This should be mentioned in at every birth. Whenever woman comes to hospital, she should be advised by everyone. So even A&M, Mamta, Anganwadi worker, they all are health professionals, and they should say to the woman that you have to take proper rest, you have to take care of these things, you have to do certain exercises. So I think these always will help in long way, and they can prevent to a certain degree this type of collapse. Sir,
actually, one point I can bring up. See, previously, the custom in our society was, yes, once an young woman has a baby, usually she is sent to her own family where she is getting special treatment and all that. Yes, now, sir, with the small family norm, she cannot do that. And yes, she has to go to work. And if yes, it's a government job where 6 months or 3 months or whatever job leave is allowed, maybe she will get some rest. But those who are manual laborers and all that, within a few days or weeks, they have to go to work. and they carry on with the work till the day they have the baby, the delivery. So social factors play a big role in this one.
Yes, yeah. Thank you, sir. So we all could understand the causes, the risk factor, the way what to diagnose. So, sir, what do you think? What are the conservative ways to manage such type of relapse? So we should not jump to surgery initially. So what do you think? What are the ways conservatively we can treat these women with prolapse? Yeah.
Prolapse is one of different grades. We can get somebody coming who's very sensitive about it with a little bulge of the anterior wall, which is the commonest. And then once they are educated and very self-conscious, they may come complaining of that. At that stage, if you probably teach them the Kegels exercise properly, that may give some relief for them, the pelvic floor exercises. Whereas once it has come to a significant degree where the leading point has come below the level, that is the hymenal rim, and or much beyond that, thereafter Kegel exercise is not going to help much. The next question is, can we have conservative approach? I'm sorry, approach like the pessary. I'm not a very big fan of pessaries, but I do admit that properly utilized, pessaries have a role, especially in those who cannot undergo a surgical treatment. But we should use the proper type of pessary. One thing that bothers me a lot is the type of pessary available is usually the plastic ones, the rigid ones, rather than the silicone ones. If the silicone, pliable, very smooth pessary is used, it doesn't usually erode that much into the walls. Whereas if the rigid ones, the plastic ones, which get more and more rigid after they continue to use it, it will erode into the vaginal walls. The other day I had to cut a pessary to remove it because it had eroded deeper, gone deeper into the vaginal wall. There have been occasions where it has gone into the bladder, into the rectum and all that. So pessary, yes, in the early stages gives some symptom relief, and the principle, as we all know, is that it stretches horizontally the wall to the vagina, so that if you have a reasonable pelvic levator complex below that, it will be kept above that level and symptom relief will be there. But most of the time, those who come with prolapse, they have very poor levators as well. So especially those with stage 3 or 4 prolapse, pessary may not give much, the usual type of ring pessary, unless of course you have the cup and stem pessary where there is something to hold it up. But that is so cumbersome. I don't know how many will use it. In the West, especially in the UK, as far as I know, pessary is much more popular than it is in our country, in India. There, the difference is once a lady is fitted with a pessary and goes home, she gets care at home. House visits are there for health workers who will go, attend to it, clean it, and reintroduce it. Whereas in our country, once you give a pessary and the woman finds some relief, she forgets about it for months on end, and then later, only when it has eroded into and purulent discharge comes, she will come for treatment. So this is the problem with pessary. So to answer your question straight away, there is not much we can do. Pessaries may give symptomatic relief, but not the final answer. Early stages, Kegel's exercise or exercise to strengthen the pelvic floor may help to some extent, but again, it's not really the answer that we want to have.
Sir, nowadays many energy sources are also being used. I don't know what is the effect like laser, MCLR chair, radio frequency. So what do you think? Are they helpful?
I think I will wait further to comment on that because you know all these new fancy things when they come, always there are many takers, and this is a symptom. It is not a big disease like say, for example, fever you can measure.
Yes.
Here it is very difficult. We can of course quantify it, but the woman's perception of it is difficult to measure. So once she feels that she has spent so much and there is some effect, people are likely to say yes. Unless we have a proper large-scale randomized control trial, it is difficult to comment on that. There are many claims about it, regenerative medicine, and of course stem cell therapy, laser, all these things have been talked about. Personally, I don't have much experience with it, so it may not be fair on my part to comment on it. Second thing, I think it's too early to make conclusions on that. That's my feeling.
Okay, sir. So yeah, so laser has been popularized many times. I think many hospitals are having laser. Even I have also laser. So I don't think it will be of great help in the severe degree of prolapse, but still, in mild cases where the woman is reluctant to go for any surgery, we can offer sometimes along with Kegel exercise, because that is better than laser or anything else. Sir, what do you think? What will be the best surgery for pelvic organ prolapse, both in younger age group and in old age group? What do you think? So there are so many surgeries. So what do you think? What should be
Let's
best?
take the younger age group. The
Yeah.
younger age group prolapse is the one actually which needs to be treated properly and correctly, because otherwise, not only that they have to suffer for long, and they are active working women most of the time, and relief from this symptom is essential for them. And fortunately for us, one of the sling procedures, any one of them, which is best suitable and known to the surgeon, should be the one. As far as I am concerned, I am a bit partial about it. I do a sling with mesh, and the one that I prefer is laparoscopic Khanna procedure. Khanna, as you know, Brigadier Khanna from Delhi, was the one who promoted anchoring of the cervix to the lateral end of the inguinal ligament
Yes.
by open surgery. I modified it to the extent saying that we can apply the sling, that is polypropylene tape, not meslin tape, which was originally suggested. We don't recommend meslin tape. Macroporous sling is applied to the back of the cervix by vaginal route and then taken laparoscopically between the two layers of the broad ligament and anchored to the lateral end of the inguinal ligament. That's my technique of doing laparoscopic, and I'm quite happy with it. And we have done more than 300 or so of this procedure. Quite happy about it. But of course, there are other slings. You can modify the slings by anchoring it to the sacral, presacral ligament.
Okay. Yeah.
There is the pectineal ligament anchorage now. All these things are there. So that is for the young prolapse. But for the massive prolapse in the older age group, what to do? There are many different approaches to it. Surgically, for them, I do transvaginal prolapse surgery, anchor the levels to higher points which are reliable. My own preference is transvaginally either use the high uterosacral ligaments or sacrospinous ligaments. I do more of sacrospinous ligament, which is more sturdy, but it has the problem that when you do the sacrospinous ligament anchorage, there is the drag of the anterior compartment and more chance of cystocele. So along with sacrospinous ligament fixation, I do paravaginal dissection. That too can be done vaginally, where you anchor the lateral sulcus to the arcus tendineus fascia pelvis, reform the lateral sulcus so that the drag posteriorly will be less. So my own preference is, if you are doing without mesh, do the level specific repair, but incorporate anchorage to strong structures like either the uterosacral or the sacrospinous ligament, and do the paravaginal repair. If it is a posterior compartment, especially a rectocele and a high rectocele, about 90% of them may be due to detachment of the denominal fascia from the perineal body. So it is relatively simple surgery. We bring back the detached denominal fascia to the perineal body. And we can easily appreciate it when you do the rectal examination. So level specific repair is what I would suggest. For an anterior compartment, if it is a facial repair, again, the difference I promote is when you do the dissection, leave the fascia with the vagina and not onto the bladder, and trim the fascia from the vaginal wall and bring the fascia to support the bladder, rather than take a purse string on the bladder. That is one. So anterior compartment repair, whenever there is lateral sulcus deficiency, reconstruct that lateral sulcus by anchorage, by the paravaginal repair, anchoring it to the arcus tendineus fascia pelvis, AFLP. Posteriorly, denominal fascia. But for level 1, support, I use most of the time the sacrospinous ligament or the proximal part of the uterosacral ligament. So this is what we do. But when there is a massive prolapse, I believe that the simplest way to tackle it is using mesh vaginally. Macroporous, very soft polypropylene mesh applied properly doesn't have the so-called frightening complications that have been mentioned in the literature, on the basis of which mesh has been abandoned in the Western world.
Yes, sir.
I do from the late 1990s, I started doing, from 2007 regularly doing, and I am not abandoning it. But we have to have the proper type of mesh.
Okay.
I am
So,
not
sir, mesh should
promoting.
be kept, mesh should be kept at what level? At the level of issue?
No,
Anterior
this is
compartment?
an 8-point fixation. So it goes supporting the bladder, then go
Yes,
to the
sir.
vault, then coming
Okay.
back to the posterior wall. So it is actually
Okay.
anterior, vault, and posterior compartments.
Oh, so this
So
should be fixed. Mesh should be fixed, right?
same sheet of mesh with side anchorage. A
Okay.
tail going through the obturator internus, anchoring to the sacrospinous ligament, and then lower down anchoring to the perineal body. So it's 8 points of fixation on both sides.
Okay.
Once we started to do that, and thin, macroporous, soft polypropylene mesh, all these points are important.
Okay, sir. So yeah, so I think this is a very new thing for me, because we have learned different methods of doing surgery in a labs,
No,
but
the
this
Western
is
literature doesn't
really
support
new,
it.
and we want to see the surgery also, sir. If possible,
Yeah,
I
if you
will
talk
get
about
it
it,
done. Yeah.
if you talk about it in America or UK or France to some extent different, US and all that, Australia, they will say, oh, this age, and you use it. But if you go to the Asian countries,
Yes, sir.
especially Japan, China, Malaysia, Thailand, all these places, it is still popular. People use
Okay.
it.
Okay, sir. So, okay, very nice. Sir, just a few questions. So what are the ways of converting knowledge into effective practice? Because we all know prolapse is full of risk factors. Women should have knowledge. And what are the ways that this knowledge should be converted into practice so that the women can understand and the society should help? So what are the ways? Just enumerate a few.
There are two approaches to it. One, the clients, that is our patients, or the women who suffer from prolapse, or the women as a whole, should be aware of this potential problem. And at the earliest stage, if they seek help, then before it gets to a really bad stage, they can get relief for that and repair it at an early stage. The other side is, unfortunately, if they come to us, the gynecologists these days, our young generation is not equipped to tackle it, because
Yes,
vaginal surgery as such was sidelined, and endoscopy surgery has taken over, or open surgery has taken over, and they have started to do laparoscopic hysterectomy for even prolapse and the uterus lying outside. Get back with laparoscope like that. So I think we have to strike a balance. When there is an associated prolapse, we can very well tackle it vaginally rather than go abdominally. That is
yes.
the one thing regarding this profession. We have to improve the vaginal approach for these conditions, which will be so much simpler. The patient can have this under regional anesthesia, not under general anesthesia. Even very older age group people can do it. And the other point to remember is, if they are not very anesthesia fit patients, we can even do some of these under local anesthesia. You may probably remember the Leaford surgery was originally brought in to be done under local anesthesia and colpoclysis like that. Now many people do colpoclysis under spinal and all that. So whatever it is, I think the profession has to realize the need for this and improvise newer technique and train the younger generation for that. One other point I have to say is, colpoclysis is a procedure people jump at. Oh, we can do it. She is 70, so she doesn't need. I think we have to remember the sexual practices in our society has changed. Just because somebody is postmenopausal, they don't stop having sex. It used to be like that in the previous generation, but it's changed. So jumping in to do a colpoclysis at the drop of the hat is not the right thing. We can easily convert a prolapse, that is inverted vagina, into a normal type vagina with a canal so that they can enjoy the anatomical normalcy as well as have sexual contact if they have to have it. So I think a rethink on the way to tackle prolapse is required, and we have to train our younger generation, and vaginal surgery is to be promoted at all levels. Thank you.
Thank you so much, sir. Sir, just I want to know what should be the last message for us, for gynecologists, that we should all learn the newer things, especially this mess. So this should be popularized, sir. And also the, every girl should, every student should know the method of optical classification at the college level. Yeah, yes, sir.
When you say about the mesh, I think we have to take the steps a little cautiously, because what happened with the mesh about 30 years, 20 years ago, we should not forget. Because mesh was promoted by the companies, and the company representatives started to go and teach senior gynecologists how to apply this. And without proper training, they started to promote. And that was the reason for the mesh getting into the mess that it is now. All the American the FDA banned it to the extent that no company is allowed to produce it in the US now. And because they stopped producing, it's not available for Japan and all that. But Japan, being what Japan is, they started to manufacture on their own. China is manufacturing on their own mesh kits. Whereas for people like us who depend on the so-called developed countries like the British, the Americans and all that, we don't have mesh kits available now. That is the plight that we have now. So we also should start. And there are some people, innovative in our country, who are doing it. I know of gynecologists in very far apart, underprivileged areas using the mosquito net as mesh.
Okay.
Very surprising to hear that.
Yes, sir.
But I'm not surprised because the polyethylene, which is the constituent of the mosquito net, is by behavior-wise not very different from the polypropylene that is the component of the usual mesh kits. And there are, I should say the name also, there is one Dr. Reddy in Telangana who has been promoting it. And he has been promoting it for decades now. He's quite happy about it. Only thing is, we don't do such proper studies with it. Anecdotal reports like that may not be reliable. But I know of other surgeons, gynecologists also using it. So I think there's a need for us to come together and see whether the mesh is as bad as it is projected. Because the companies do not promote it, because in case one complication occurs and the compensation asked for is in millions, and the company will get dissolved. That is why the big companies in America stop doing it. So here we have to cautiously go when we talk about promoting mesh. Without proper training, nobody should apply the mesh vaginally. But you should remember that they are applying mesh laparoscopically. It also has the same type of problems. Erosion is not unique to vaginal approach. It is there, of course, a little less by laparoscopic approach also. I feel that mesh is to be encouraged when the supports are weak. But properly trained people only should use it, and it should be applied with proper case selection. That's my feeling.
Yes, sir. We will like to see the video also, sir, next time. So, sir, thank you so much for your valuable time. You could join in spite of your busy schedule. So I'm really thankful to you, sir. I am honored and I am privileged. And I wish you, sir, very good health and long life and knowledgeable life, and so that you can spread more and more knowledge to all of us. So thank you so much, sir, and wish you a very good, very Christmas and Happy New Year also. So
thank you very much. Thank you, Kavita, and a very bright future as well as Happy New Year to all of you.
Thank you, sir. Yeah, thank you. I would like to hear, we all will like to see your video, sir. So thank you, sir. Thank you for joining that podcast. Thank you.